Hello, everyone. My name is Jasmine Meyer, and today I'll be presenting on schizoaffective disorder, specifically how its overlap with schizophrenia and bipolar disorder affects diagnosis, treatment, and how counselors can most effectively support clients. Here is an overview of what we will cover today. First, I'll explain what schizoaffective disorder is and why it's considered a complex diagnosis on the schizophrenia disorder spectrum. We will then discuss key medications and pharmacological considerations, and we will explore how these medications impact counseling work, both positively and through challenges. And then we will finally touch on ethical considerations and the need and trajectory of future research. So, what schizoaffective disorder is, or SAD, as we will be referring to from here on out, is a condition characterized by symptoms of both schizophrenia and a mood disorder, either through two different subtypes, bipolar or depressive type. This means that clients may experience hallucinations, delusions, disorganized thinking, as well as mood episodes like depression or mania. Many researchers describe SAD as the middle ground on the schizophrenia spectrum disorder. And the middle ground is also considered where a lot of the diagnostic uncertainty comes from. One of the largest challenges right now is that symptoms fluctuate throughout time, which means that clients can often slide through the schizophrenia spectrum disorder scale, and their diagnosis can then change as well. And this ambiguity of diagnosis leads to medication uncertainty. So, understanding the overlap between schizophrenia and bipolar disorder is incredibly imperative for clinicians to identify symptoms and guide the client through medication selection and hone in on their therapeutic focus for the client. So, the diagnostic complexity of this disorder lies within the DSM-5-TR diagnosis or criterion. So the criteria for SAD requires clear evidence of psychotic symptoms such as delusions or hallucinations, which should last for at least 2 weeks without mood symptoms. But mood symptoms must also be present for the majority of the disorder's duration. So, as you can probably hear from that, it is quite unclear and a little ambiguous. So, as we talked about previously, SAD has two subtypes. There's the bipolar type, which is where a manic episode is present, and a major depressive episode may occur during this period as well. However, the depressive type, only depression is present. So it is incredibly important that counselors understand this spectrum and not just the label of it. It's crucial for diagnostic changes and treatment consistency. So our current counseling discourse and the relevancy in counseling. Why does this matter to us as counselors? Because unclear diagnostic boundaries often lead to unclear treatment paths. If a client is experiencing mania and hallucinations, are we treating bipolar 1 with psychotic features or SAD bipolar type? If depression occurs without mania, are we treating major depressive disorder with psychosis or SAD bipolar type? These decisions affect medication selection, which is not entirely in our scope. We are not prescribing, but it is important that we understand the impact of these symptoms, the side effects of the medications, um, because we will be providing counseling, and what route are we going to be taking in counseling. So, the key pharmacology and medications are pretty important. We have three main medications that are prescribed and used to treat SAD: antipsychotics, antidepressants, and mood stabilizers. So, antipsychotics treat the schizophrenia symptoms such as hallucinations. This is the foundation of SAD because psychosis must be addressed for any therapy to be effective. And this is what will target the positive symptoms, which is hallucinations. And it can also help with the negative symptoms, such as social withdrawal. So you have atypical and typical antipsychotics that can be prescribed. For mood stabilizers, lithium is probably the most common prescribed, and it is essential for the bipolar type of SAD. It also has a very high effectiveness in lowering suicide risk. And again, there's also atypical prescriptions for that as well. Antidepressants, often SSRIs, again, the most common. This will be particularly useful for the depressive subtype. However, there have been a few studies and research that argues about the possibility of antidepressants triggering mania. So counselors must be aware of that. There is new research coming out that is rebuking that, but still, it's not a positive one-shoe-fits-all study. It could very well still be triggering mania in some clients, so we need to keep an eye out for that. An important thing to note is that most patients of SAD are polypharmacy, so they are being prescribed multiple medications simultaneously, and these carry risks because you can have increased side effects. You have side effects in each different category of medication, and when you're prescribing multiple of those, you have an increase in possible side effects. So, what are these medication side effects, and what do we as therapists or counselors need to look out for? In the therapy room, we are seeing them probably more frequently than their prescriber is seeing them. So it's important that we, one, have a very open communication with our client and their medical team, and that we can witness these patterns and symptoms to prevent any adverse effects of these medications. So with antipsychotics, you can have cognitive slowing, which can make it difficult to process interventions, particularly in CBT. Common with antidepressants is emotional blunting, which is that reduced affect and withdrawal symptoms that you typically see with schizophrenia or depression. You can also have medication-related sedation. So if your client is missing multiple appointments, having multiple work or school absences, and a decreased motivation, those are all symptoms of adverse medication side effects. Possibly they're not taking the correct medication for them, or even non-adhering to medication. Which also goes into irritability and agitation and a recurrence of symptoms. If their symptoms are worsening or staying the same, it could be ineffective medications or non-adherence of medications. emerging psychotic symptoms, as we previously talked about, you could have medication-induced mania, hallucinations, paranoia. It's important to monitor for changes in symptoms, as individuals, as we talked about before, may slide through the schizophrenia disorder spectrum. Further complications of medications. A major complication in treating SAD is polypharmacy itself. When you are taking multiple medications, you have an increased side effect risk. You have weight gain, sedation, sexual dysfunction, dehydration, possible seizures. There's a multitude of side effects that rise when you are taking multiple medications. You need to know if the medications will work well together, and if they work well with that client. So that 2014 study by Victorin is the study that argued antidepressants trigger mania in bipolar patients. In 2023, they just came out with another study, Jeffson et al., that rebuked that and said, mania occurs prior to initial antidepressant administration. So I'd love to see more future research on this particular concept, but that's where we are currently in the research. So, effects in counseling. It is incredibly important that the intake process is very detailed. Counselors must accurately identify mood episodes, psychotic symptoms, family history, and potential other medical contributors, and ongoing therapy throughout the entire process. It's incredibly important that the counselor maintains informed consent throughout the entire process. Medication adherence is another large role. Many clients stop medications because of the side effects, and so psychoeducation is really important for that, and really including the family and the patient in the psychoeducation, because a support system is incredibly beneficial for recovery and reduced relapse. So the challenges and ethical considerations. Again, I can't emphasize this enough. Polypharmacy has increased side effect risks. Supporting medication adherence while also monitoring symptoms for correct medications and dosages, and informed consent throughout the entire process, as we just spoke about. To go in more detail, if your patient is in a current state of psychosis, it is important to continuously provide informed consent to your patient, especially when they're in their calm and regulated state, so that they're aware of everything that is happening, everything that's being discussed, the medications, the psychoeducation. Informed consent is incredibly important. It's our ethical obligation, it's our legal obligation, and it's challenging because you're going to have to consistently bring up informed consent and bring up all of these challenges to the client and the family throughout the entire process. So in conclusion, schizoaffective disorder is difficult to diagnose and challenging to treat because it requires balancing medications in conjunction with balancing therapy. Medication, often in combination with therapy, is the most beneficial for stabilizing clients, and essential for relapse prevention, adherence, and really building a support system for the client as well with their family and their social network. Because diagnostic uncertainty remains high, continuing research is needed to clarify best practices, and give counselors more guidelines for the treatment standards for SAD to support clients effectively and maintain their safety. Thank you.